Good evening, everybody. Today, that we are having two speakers, the eminent speakers, Dr. Sreevidya and Dr. Anusha. You see, nowadays, infection. So everywhere infection is there. So today's topic mainly on the infection control audits, best practice, key strategies, and effective implementation. Coming to the first speaker, today's the main infection control audits is Dr. Sreevidya. She is a consultant microbiologist and head of laboratory services, infection control officer, NABH assessor, Apollo Specialty Hospitals, OMR, Chennai. She has done an MBBS, DNB in clinical microbiology, MBA hospital administration with a work experience of 18 years post MBBS in various hospitals. She has earned 9 awards in the last 3 years for Kaizen, quality improvement, POCA, UK, AMSP, antimicrobial resistant, infection control, and won the AHPI India and Global Conclave Award in Excellence in Infection Control Practices for the January 2025. She has played significant role in NABS certification for the hospital, good compliance, and completed her pre-assessorship course in NABH. The government certified green belt in Lean Six Sigma has further enlightened her data analysis knowledge. She has been regular in auditing facilities and various areas of the hospital. She is an ardent reader and a recognized writer for the hospital contesting in various events. She has over 20 publications in peer-reviewed journals and many oral lectures, conferences, posters, presentations as academic feat. She has been trained interns, students, and PhD scholars, and her areas of interest is clinical excellence, administrative, managerial, quality, infection control, AMSP, hospital accreditation, risk management, audits, patient safety, good clinical outcome, communication, and soft skill development, and many more. And we have a very good speaker after this, Dr. Anusha. Now I will ask Sreevidya to take over. Over to you, Dr. Sreevidya.
Thank you, sir, for that elaborate description. So it was like a revision of my resume. So thank you. So I think I'll start off with very basic of how we design an infection control audit. I think that is where most of us, we just do an audit for the sake of doing it. So how do we go about it? Why do we call it an effective monitoring tool? I think every word which I've used here as the introduction slide, I think it says it all. So obviously, whatever we do in the hospital scenario, it should have an impact. It should be meaningful, and obviously, it has to be sustained. So what I see is many people when they join their career, no, they are over enthusiastic. So I think the first year when they join a workplace, they want to do everything in the first year, and then it all fizzles out. So I think it is always nice to do things in a very gradual and slow paced, the tortoise speed manner, and then hit it hard so that we can sustain and we can reevaluate what we have left, over prior years. So please change the slide, Akshita. So firstly, what do we mean by an infection control audit? So this actually comes under the purview of a clinical audit. So basically, when we want an improvement in already existing practices, so it is like good, better, and best. So if we want to take it to the next level, we can only do it by understanding the gaps, the deficiencies, systematic reviews. So that is how an infection control audit plays. And it is always good to design and designate areas. So if you can also start an infection control audit with a very, very small area. So if you have a group, you can kind of disassemble the group into various small subgroups. Say there is an infection control nurse. I think infection control nurse actually plays a very, very pivotal role in most of the organizations. Like people are actually asking for more and more ICNs because that is how the job is run these days. So one infection and then the patient never comes back to you. So that is how important the role of an ICN is. So if we have a small subgroup which may have an ICN, it may have a link nurse along with the ICN, obviously an infection control officer, somebody from the quality team. If you have a person who's into epidemiology, you bring that person in as well. And it is always good to have somebody from the management side because they are the ones who will give you the finance for conducting these audits and also bridging the gaps. So basically, it is just a systematic review of any departmental area. It could be a high risk area, it could be a low risk area, and you have to compare the practices which are established there with standard guidelines and protocols. So I have just kept WHO and CDC as an example, but there are many more. It depends on how people want to design and how they want to go about. So basically, only when we want to bring in a change, that is when we audit. Audit is not, it's not just done that because other hospitals are doing or one NABH assessment is going to happen, so we audit the place. It is only when we want to bring a major strategic change and process improvement, that is where infection control audits come into play. So I think we can go with the next slide, Akshita. So there are two terms which are used very commonly, surveillance and audit. So many people think they are synonymous, but it's actually not. So surveillance is more a little more superficial, but audits are more structured. But however, the final link of the surveillance chain or the audit chain would be to apply whatever we find in the form of data, because any audit has to be measurable. That is only when it makes sense, and you have to put it into practice so that your prevention and control aspects of infection become better. So are they safe? Definitely not. And as I was saying, the next slide, Akshita. Yeah. So are they safe? Definitely not. But obviously they have some common objectives and common goals which lead to a pathway, but one is more generic and the other is more specific. So in audits, there is always an assessment of whether the standards are being followed or not, whether the compliance is good or not. So only when we have this background of what an audit exactly is for infection control, only then we can carry it forward. Because what we see is many people, take out from the net checklists and guidelines, which may not even apply to their indigenous setup. So unless you know what is exactly the problem in your hospital, you will not audit and you will not want to carry it forward for a better perspective. Next slide. So why are we auditing? Obviously, to find the gaps as well as the strengths. So any audit, we see that many times we have auditors coming in, external or internal. So they will give us a list of all the deficiencies of the hospital scenario. But I think the purpose of an audit is also to identify the strengths, because those strengths can be implemented in some other healthcare organization where there are minor gaps or there are deficiencies. And especially these gaps are important in high risk settings. In high risk settings, because these are the critical care areas of the hospital. In my next slide, I'll be showing you which are the high risk areas which we specify in a hospital. And obviously, whichever practice is good, we make that better. And whichever practices are already best, that has to be further reinforced. They have to be sustained. And the ultimate goal is to reduce the healthcare associated infections, because that is where our challenge is. So if in any hospital they project data saying that there has been no healthcare infections, there has been no multi-drug resistant organisms, we know that it is all goofed up, because in today's scenario, it can never be that there are no infections. And it is always good to project your rate of infection so that you can make the outcomes better. Next slide, Akshita. So audits are also a crucial method for identifying areas of improvement. So whenever we do an audit in a hospital, say we can either do it in a planned manner with a quality calendar. We have a QIP calendar, a planned audit. So whenever there is a planned audit, you can be sure that everything is going to work right, because people know that such and such team is going to visit us today, Monday morning at 11 o'clock. So this is a planned audit, and they will ensure that everything is kept spick and span, so that you don't get any findings. So that is how one planned audit is conducted. You can do those audits maybe weekly, based on the high risk areas. You can do them once in 3 months, or you can also do annual audits. And obviously you have to identify these areas of improvement, work upon it, so that patient safety is ensured. The crux of the problem is we are always able to identify problems, but when you want to handle solutions, that is where it becomes tough. Because when you want to seek solutions, it is obviously it's a conjoint team work, because it's always easy to do fault finding, but when you have to lay down the streamline straight, that is when many departments may have to pitch in and work towards solving that problem. Next slide. So this is the high risk area in the hospital. So we can categorize the risk areas as low, medium, and high. Low doesn't mean that if there's any infection there, we really don't bother. It is just to show that these are the non-clinical areas of the hospital, like the front office, and not directly related to patient care areas. Our worry is always with the high risk. Wherever there is a constant inflow of patients, you see, most of the hospitals, you will always be having a constant inflow of patients. Say one patient is getting discharged, there is not even adequate time for the next patient to be put into the same bed. So that is where all these protocols are very, very important, because we don't want one infection carrying on from one patient to another. And obviously other areas like the OT, the cath lab, the CSSD, delivery rooms, the ICUs, NICUs, the negative pressure rooms, the ER, even our FNBs, and our cardiology, pharmacy units, radiology departments. I think all of these are high risk areas, because one infection here, I think the outcome is bad. The reputation of the healthcare organization, it goes down the drain, and then to bring it back to square one, it takes a very, very long time. The next slide, please. So how do we do a processing of an infection control audit? Obviously, there will be some written guidelines. So in many hospitals of the urban settings, or which are more than 100 bedded, 150 bedded, what we see is many things are very properly placed and documented. But are these documents being updated? Are these written guidelines made aware to everybody in the hospital? So that is where we have to review these guidelines. There will be some policies, there will be some SOPs. So that all becomes a part of the audit process. Obviously, observe practices. So mostly physical audits are always much better than online audits, because in online audits, it is always nice to see the layout, the infrastructure, how the air is flowing across the OTs, how trafficy the OT areas are, how good are people aware of the use of the PPEs or the gloves, how are they using their hand rubs, how are they keeping their hand hygiene. So for all these purposes, physical audits are always much better than any desktop assessments, because you can observe all the practices in person. And obviously, most of the audits should be considered in a very, very unbiased manner. Say, for example, if we are going into a CCU and the head of the CCU is a good friend of mine, it doesn't mean that whatever principles are being followed there, are right. I should have my say. So it has to be absolutely unbiased. And if they have a policy, are they adhering to it? Are they following all the guidelines? Because many times we have seen that things are written and not followed. And people are expert in putting on documents. So it is like making the khichdi. So they put in everything together. They stay, awake till 12 o'clock midnight. The moment they hear that, there's some auditing which is going to happen, because they feel audit means your document should be pakka. But that is not how an audit runs. It is how you are adhering to whatever is being written in the document. That is the role of an IC team who is going in for an audit, and it should just happen that way. Sometimes too much of hype, what happens, people also get a little panicky. So audits always have to be very smooth, and even random audits are good for that matter. So irrespective of the planned audits, you also just walk in. It can just be a casual walk, say through a endoscopy unit or through a dialysis unit. Like you just go for a friendly chat, but you note down the points. So that is where the entire processing tunes in. Next slide, please. Next slide, please. Yes. So no, the previous one. The previous one, yeah. So we can actually pick up our own areas of infection control. Infection control is a very, very huge area. So it is not only restricted, just to OT care or the wards or the ICUs. You can start it right from the moment a patient enters the hospital till he leaves the hospital premises, along with the people who are visiting the hospital. So you can audit every little area. So sometimes it is good to go floor wise. Sometimes, audits can be vertical or horizontal, or you can choose specific areas which you want to audit. For example, hand hygiene. I think most of the hospitals are having these observation tool hand hygiene forms, so that people know that through your hands only most of the contaminations and most of the infections are being passed on from the healthcare worker to patients. So this is the main thrust in most of the hospitals. So if your hand hygiene auditing is done in a nice way, with feedback, with implementation, with a change after the audit, I think that is where the audit cycle closes. Then use of PPEs. In many of the rural settings, they do not have adequate PPEs at all. I think those who are from the cities working in corporates, I think we are much more luckier that at least the management supports us with what we have. But in restricted infrastructure also, they should have their basics. So that is also a part of the auditing area. Obviously, environmental cleaning. So housekeeping practices put in together with disinfection of the hospital. How regularly are they cleaning the floor? That can be an area of audit. And hypochlorite also be broken down into parts. Then you have patient care areas. You also have high risk areas. So I was telling you, high risk areas has always been a concern, because that is where, like for a CCU, most of the sick patients are there. Most of the hospital acquired infections can come out of the CCU. You can have all deadly bugs coming out. So that is one major area. So apart from your regular audits, I think in most hospitals, they first want to keep their CCUs clean, their ERs clean, their OT clean. So they feel that itself will kind of limit your infection rate. OP procedures. Sometimes you have people with infected diabetic foot coming into your treatment room. So there you can audit. Is the sister following all the principles of all the intervention methods? Is she kind of cleaning that sheet? Is she disposing it? Are they using disposables? If they are using curtains, are those curtains disposable? So in audits, it has to be if, and why. So if all these ifs and whys are answered, then most of your audits are closed. Then obviously biomedical waste, that is a very, very important area, because most of us outsource those biomedical waste of the hospital to a third party. So how are we tracking it? How are we sending it? How are they managing it? So our work doesn't stop in the hospital. We have to visit the on-site places, off-site places. We have to see whether they are doing the processing there. We have to give them suggestions. We audit those areas as well. So if you really want that entire cycle to become a kind of a Brahmastra cycle, you have to really work hard at it. Then antimicrobial stewardship. So if people with AMSP, knowledge and all, we know that unnecessarily, inadvertently, we will not use high-end antibiotics. Are we having high-end restricted forms, antibiotic forms? We can audit those forms. Like, are those forms being properly written? Like, I hope that the patient is not being given something without the knowledge of the consultant. Is there an ID physician? Is there a microbiologist? Is there a CCU physician who's trying to tell them that no, you will not use this colistin here? So every area we can audit. Then obviously you can also go into your OP pharmacy, IP pharmacy, how they are dispensing the drugs. Are they giving over the counter antibiotics? That is an area of audit. Whether they are keeping a track of how many antibiotics are being consumed by the hospital. And of course, for the ICN, you have a major area of care bundles. Like, by how are they inserting an IV line? Are they cleaning their catheters properly? If there are surgical site infections, then what is the rate? What is the root cause? So for every audit, it is like, if you want to conduct an audit in a very in an unbiased and in a very transparent way, so one audit for one area itself can take more than half a day, if you want to go into all the points in a meticulous manner. Next slide, Akshita. Yes, so this was just a fun slide that sometimes we, as I was saying, we are all over enthusiastic, especially during our appraisal periods when we want some increment. That is where you will see the entire hospital doing audit somewhere. I mean, apart from infection control. So the quality team and everybody is like on the toes the whole time. And then you suddenly realize, oh, it's April. So our boss has to kind of write the appraisals. But the crux is you have to be consistent. So I think people themselves are cameras these days. So you don't need your 3D cameras anymore, because people always keep a watch of what's happening. So be as consistent as the BMW and as fast as the Storm. Why I mentioned this is, we send our biomedical waste to a place called GJ. I think most of the Tamil Nadu centers do that. And obviously our laundry linen is also outsourced, which is called Storm. So if you can see, you can audit all of these areas. Tracking of the biomedical waste which is being put in the bins here, how the person is taking those, how some of us have a GPS tracker to see whether he's actually reaching the destination, or he's sitting down for a chai and taking out half the laundry and linen and throwing it out somewhere. So every part of it you can audit and you can monitor. Next slide. So whenever we think of any audit, we talk of how we design an audit, how we process an audit, and obviously the outcome. So without the proper outcome of the audit, the implementation is not going to work. So in your outcome, if there is any deficiency in your policies, we can revise. And obviously area of improvement, you have to identify. Based on that improvement related areas, you can design your training after an audit. And obviously everything leads to patient safety and occupational safety. So it is not only our responsibility to keep the hospital clean for the patients, but what about those healthcare workers who are working here day in and day out? How are they keeping themselves safe? Because we have seen that in laboratory, you have the microbiology lab. So how are they handling the samples there? Because we always read that treat every sample as potentially infectious. I think that is one line which is like the Gita and the Bible, which we all read and we answer in our Viva. But still we see people don't use the right kind of gloves when they're handling samples. So it is not necessary that any of these samples which come into the lab, the patient has just come for a health check, so he doesn't have any problem. That is just an assumption, because many times we have picked up so many retro positive cases for in normal AHCs and MHC checkup. So all these are outcomes of conducting a proper audit, so that you can revise, train and retrain your staff, and you can extend your training to patients and patient attendees, because they are the people who are going to take care of the patient once the patient goes home. So that whole process can be audited. Next slide. And what are the benefits of doing an audit in a methodological way and in a meticulous way is obviously better patient outcomes, cost effective. So whenever there is a gap analysis, it doesn't mean that we are actually criticizing that there is a gap. We are trying to understand how exactly you can frame in your budget effectively and also reduce those gaps in that system. For example, if in a say in a nursing station there is inadequacy of mask, okay, N95 mask, and you have identified it, so immediately you will see the nursing lead, she's like, ma'am, why did you put the mail to GM, sir? This is a regular question we get, that if you find something, they want that you shouldn't tell, but the purpose of the audit is to escalate and to get things done. So we have to explain that if you don't wear an N95 during a COVID case, what is going to be the cost if you fall ill and you get a COVID, because the test of COVID also is pretty high. So you might as well wear one N95 and try to prevent that COVID infection at all. So that is how it will be cost effective, and obviously to reduce healthcare infection. I think for any infection and prevention control professional, we want to reduce healthcare, because we can never say that there will be no healthcare infection. It can never be 0%, but whatever your rate is, in 6 months when you're doing the next audit, it should have come down. So that is how our vision should be. And obviously with all these accreditations for all hospitals, say NABH or JCI, you have to increase your compliance rate. So if you have an hand hygiene of 90%, you have to take it to 100, at least by 6 months to 1 year. That should be your target. So most of your audits can also be targeted. So those are these targeted audits. So, and all audits have to be measured, all have to be quantified. Next slide, please. So in audits, we also try to bring in risk assessments in infection control. So this is just to show that a WHO framework of an assessment tool, how we use the assessment tool, whether the infection rate is mild, it's moderate or severe, what is the category, whether it's 5 or 4 or 3. So these ICRA guidelines can be designed by your unit as well. It can be organization specific, or you can follow some other guideline. Next slide, please. So when you want to complete one audit cycle, it is always good to have a questionnaire which is competency based. So say you're going for a planned audit. Before you go for the audit, you can give a set of questions. You can give it to the people working in that specific department. Say I want to go and audit the ER. So I can ask some basic questions. Either I can interview the staff, or I can give them a questionnaire that these are the questions. Let me see how much do you know. Then you audit, and obviously the feedback. So that is how you complete the cycle of an audit. So nothing is complete till a feedback is given, and you work upon the feedback given. So that is where the important aspect is. So now in healthcare also, we all take Google reviews for many patients. But if patients have a set of complaints, then how are we doing justice unless we are addressing their complaints? So that is where your audit cycle will complete. Next slide, please. And most of the audits have these set of components which are designed that whatever you're assessing, it has to have some standard adherence. Obviously, identification of areas, the best practices have to be reinforced. Patient safety it's always talked about, and tools and methods. So your tools and methods can be different. It can be designed the way you want to, but please make your tools simple and short. So because we've seen that in some audit checklists, they run for 4 pages, 5 pages. By the time you reach the 5th page, you forget what was there in point number 1. So make them simple, usage, so that you understand, the person whom you're auditing understands, and obviously when you're doing a summary and giving a feedback or report, the management also understands. So that is the purpose of an audit. So everything has to be done in a very simple way. and self-assessment framework and forms. So in many areas where you don't have too much of technology, in some of the semi-urban or semi-rural settings, there still people are, they give pamphlets, they give a lot of questions, they ask questions, and sometimes it can be a silent observation. You're just standing there and they're like, oh, this person, she's not even asking anything, but you're actually seeing what's happening. So that passively auditing also makes a lot of difference. Next slide, please. So we can classify audits in various ways, whether it's observation based, process based, targets, strategy. But mostly in infection control, we do a lot of potential or partial audits. So in potential or partial audits, for example, if I'm trying to stand in a place and observing how a person is doing her hand hygiene, what are the moments of hand hygiene, but I'm not having any target. So those will be potential audits. In partial audits, you're adding a target like percentage. So I'm doing the percentage evaluation. And full audits are comprehensive. So where you're taking everything into consideration and you're re-auditing. For example, I wanted that now the hand hygiene percentage is 90%, but I am going to re-audit and see, I'm going to repeat the cycle as a program regularly and see whether the compliance has increased. So mostly we do potential or partial and also full audits. So you can categorize the audits in that way. Next slide, please. And what do you plan in your audit? So when you go for an audit, you just can't just go with any, no basic idea of what's happening. Okay, so you want to know exactly what you want to assess. Sometimes it may happen that you have been attending some committee meeting because you're an infection control professional. They will usually drag you into all the meetings. Okay, some may be relevant to you and some may not be relevant to you, but even those are some touch points for us to learn a lot of things. So what are you wanting to assess? So there might be a talk that some outbreak has happened, but it is still undercover. People are not talking about it much in the hospital, but you being an infection control professional, you have all the right to walk into the area and see. There are two people who can walk anywhere, in the hospital. One is the quality professional. Nobody can question that why are you here, and the other is the infection control professional. Nobody can ask. I mean, apart from the leadership team. So nobody can ask, ma'am, what are you doing here today? Because we have all the right and privilege to walk in, say we have heard of something, brewing up, which is not right. We will just go in quietly, make our, mindset and go quietly and assess and come. And whether you have the available resources with you to audit. So say it is something pertaining to F&B. Many times we have faced these situations. I think this is the third time we faced something like one feed, enteral feed, and there was shivering and fever in a patient. So what do? We first understand what was supplied to the patient, how the preparation of that feed was done, under what conditions. Then you take out all the the lot numbers, the batch numbers. You keep on testing it in your microbiology lab. Okay, and before that you escalate it to the clinician or the management person, that sir, do not give this feed to this patient or to anybody till we certify that everything is okay. So and for that you will need some people with you, because say your ICN or a quality person, it is always good to take an MS or a medical head also with you. I mean, so that people at least will allow you to do what you want to do. So that will be your small audit team. And how will you share the audit results? Most of the times what we have seen is people audit, they find a lot of gaps, but they never share, because they feel the department which is having gaps, they take it very personally. So one moral is, please don't take any audit finding personally. It is never targeted on anybody. It is only targeted on the gaps in that specific area which need to be improved. So how are you going to share your audit results? So most of the time we have an audit an audit closure form. So we fill that form, or you can do it digitally also, and you escalate it to the right people. And what I have learned in my 10 years is, you please copy most of your escalations to the people who are strict and stern in your organization, then things work. So like if it is the OT person and she's like, ma'am, don't send it to anybody. You have to mark it to the higher level officials who will at least take in action. Otherwise, there is no point in doing these audits, okay? Because you're investing your energy and your time. So obviously there has to be a final closure. Next. So we always do this, plan, act, that study cycle. Then how do we prepare for an audit? You choose your tool, you train. So usually before an audit, the audit team undergoes a small briefing meeting. They talk to each other about how to conduct, and you choose the sample size. It is always good to have a small sample size initially if you're starting audits. I mean, like some people will be roaming around from top to bottom the whole day that you're auditing, so you lose focus. So you segregate smaller areas. Say I'm going to audit 50 healthcare workers to see if they are doing the hand hygiene well, whether they're using the PPEs properly, whether they are following the isolation protocols, whether they know the respiratory barriers, whether they know the contact precautions. So small areas we can pick up, and frequency is very important. Some people do one audit in a year and they forget about it. Then they do that same area audit after 3 years and nothing would have changed. So only if you define your frequency and those people are alerted, oh, it's been 3 weeks or 3 months, they're going to come to us again, only then will they do the work. Because if you lose that that streamlining, they will be in that same place where they were. And obviously your reports. Next slide, please. And audit methods, as I said, you can directly observe. It is like going and just observing, asking some questions. You can ask them to show some graphs. You can tell them you can go to the OT, place and say, what was your surgical prophylaxis antibiotic which was used? Was it given 60 minutes prior? Or was it given in the ward? Was it given in the OT? So, just casual questions. And it is always good to audit a balanced team. So when we go for audits, the nursing head, or the CCU lead, they will always choose 3 spokes, and the one who cannot answer will be in the night shift. So this is a routine protocol. Okay, so we have to pick up people who joined within a year, whether they are aware, because in every induction program of any hospital, I think they have to be trained on infection control protocols, and also people who have been in the system for 3 to 4 years, because are they still practicing? Because once you become a little senior, you try to underplay all these things. It's like, oh, this I've done all this, why should I do it now? So your observation or your auditee team should be a balanced mix, and that we have to do it very intelligently. Sometimes people push people forward to answer. I think it is best to move away and pick up somebody else and ask them whether they're aware of the protocols, and questionnaires. And it doesn't matter whichever the language, because in Tamil Nadu still many people are more comfortable with Tamil than English. So most of our questionnaires or our forms are bilingual. And obviously technology. So whether they know how to put these care bundles into the system, whether they know online tracking, if there is an incident report, do they know how to raise it? Because what happens is that usually the people who are in the lead, they know most of this. They don't want to percolate it to the lower level staff because of insecurity. Okay, but everybody in that area should know. So we have in our dialysis unit, exactly at 12 o'clock, there's one person who comes for his duty. He's the only one who knows about the level of endotoxin. He's the only one who knows about the single-use devices. He's the only one who knows how frequently the dialysis machines are being cleaned. So they will always call us at 12 o'clock. Okay, so what we decided is we'll never go at 12 o'clock. We'll either go in the morning at 8 or evening at 3, afternoon at 3, because we want to understand whether that person has even told them where the endotoxin level forms are. Do the other people know whether, what was the HCV titers, whether a patient was, HBsAg positive in the recent. So you have to do it in a very, very smart way. But most of your audits, we call it the handshake audits. Okay, we cannot be aggressive. You have to be very sweet if you want to get your work done. If you want to pick information, you have to be at your best behavior, but you pick the information and you escalate wherever you want to. Next slide, please. Next slide. Yeah. So this is just to show you one of our hand hygiene tools. It's not looking very nice though, but obviously we want to pick up the number of actions performed and the opportunities. This is just an example of in one of our tools, but there can be many more in many areas, like even in antibiotic policies, you can have antibiotic chart audits, high-end restriction form audits. You can also have these MDRO tracker audits. So there are a lot of audits which we can do even as an tool based. Next, please. So why do we want these results for? Obviously for improvement. So whenever we come to know about the deficiencies or gaps, you will create your next plan. You will know, oh, these are the areas I lack. This is how I should work. And when I start working, how do I implement? What do I do? And how these audit processes are going to impact. Okay, so that area has to be studied. Any audit is meaningful only if it has an impact on the patient healthcare and obviously on the hospital front. And any area where you want to remodify or redefine or re-educate, because see there are many guidelines which we would have followed over the years, but there have always been a little bit of pluses and minuses here and there, which we need to understand. And that is only possible when we talk more about it. Okay, because it's not possible for one person to know everything. So that is why a lot of these discussions are a mandate. Next slide, please. So this is just a conclusion. My personal thing is this area is actually a very vast area. So if you talk about audits, you can take it to multiple fronts. So if you want to talk about on best strategies, best practices of implementation, each actually is a topic on its own. Because infection control, the infection control manual itself is around 500 to 600 pages, the limited edition, because some people may write even more, but we make it a little smaller so that people at least read and understand. So that is how we do it. So obviously these infection control audits are an indispensable tool, because I think over the last 10-15 years, when microbiologists were asked to make a lot of clinical rounds, give their suggestions, opinions, and when you knew that you had infection control also as an area, where you have to work hand in hand with your microbiology team, that is when people started understanding. And thanks to COVID, I think COVID showed that microbiologists exist, and also that infection control practices can change dynamics of the community. And just a mask, okay, and just a hand rub, I think it saved so many lives. And obviously you want to monitor all the processes in your infection control practices so that there is prevention of infection and for a healthier and safer environment. So this healthier and safer environment is not only, as I said, for the patients, but for people like us, who are working in the system, so that we also know exactly how to take care of ourselves. Next slide. So this is just to show that infection control is not a single person's responsibility. So this is one of the slides which I had used for that conclave, the AHPI conclave, where every person who's standing here is actually from different departments: clinical, non-clinical, housekeeping, the front office. So because if you want to bring a change, it cannot just be the ICN and the ICO and the linked nurse and the ID person. It is not, because if you have to follow it, it has to come from everybody. So obviously coming together is just the beginning, but keeping together is progress. And if you work together, obviously we will be able to minimize infections in our hospitals. So thank you. Next slide. I think this is the best slide. Thank you.
Thank you, Dr. Sreevidya.
Thank you, sir.
Wonderful and lucid presentation. And it was so simple, and then anybody can understand what is an audit, what is a infection control audit, and other things. I think there are a few questions. Probably we will take up all the questions at the end of the second speaker.
Yeah,
is it okay? Please
yes,
be there with us till
till
the end.